morning, everyone. Welcome to Grand Rounds. Welcome to our applicants today. Today we're thrilled to have Dr. Camron Johnson from Physicians to Children presenting to us. Dr. Johnson graduated from Philadelphia College of Osteopathic Medicine and completed her pediatric residency at Geisinger Medical Center. She's called Roanoke home since 2004 and lends her time as a busy pediatrician at Physicians to Children, as a member of multiple community boards, and as a clinical preceptor for multiple residents and students. She has a strong interest in breastfeeding medicine and is currently pursuing international board certification. Please welcome Dr. Johnson.
I usually have a fairly noisy voice, so hopefully it won't be too bad. I'm really excited to be here today to talk about my favorite public health initiative, and that's something that is in the news a ton. I was super excited this month when I saw a couple things that I thought were strategically placed, just for me, not really, but Dr. Hart sends out these lovely emails every month that talk about gut health, and his gut health email this month was all about breastfeeding medicine and the association with obesity. Yes, that was a plant for me. The other thing that I saw this month was AAP News. Everybody get this? This is a newsletter put out by the American Academy of Pediatrics, and I tear things out that I like. But in the center of it, there are two articles related to breastfeeding medicine. One is written by there's a group called the American Academy section on breastfeeding medicine, and this was written by Dr. Joan Meek, and it talks a little bit about how we as pediatricians can present the evidence of breastfeeding to our patients. And the other one is written by an ACOG member, the member of the AAP Committee on Fetus and Newborn, talking about vaginal feeding for babies that are born through a C-section. And we're going to talk a little about some of these issues as we're going through today. Okay. So one of the things you'll know about me if you spend time with me is I love to travel. This is my sister in Germany, and that is her exclusively breastfed 6-month-old. We were about to hike the medieval trail, but it's actually the medieval wall of the city of Esslingen, and we traveled together and would stop along the way so that she could breastfeed her baby. Different cultures have different expectations of how you breastfeed in the community. Germany is pretty similar to the U.S. It's accepted, but there's a little bit of shame that's associated with it. Versus when I was in Guatemala this summer, breastfeeding was everywhere all the time. You would be in the middle of talking to someone, and they would take out their breast. Almost all of their shirts are open, so that they can do that at any time. So that's truly breastfeeding on demand. Today, we're going to talk about some different things, not the societal portions of it. I want to talk to you a little about how the immune system changes in response to breastfeeding. I want you to talk a little bit about what that means long term. We're going to talk about some of the global initiatives that are out there, both from the nation of the United States as well as for the world. And then we'll also talk about some things that we as physicians and providers can do to help spearhead this and support our mommies through the process. So let's talk a little bit about what's in milk. Is it clear? So it has a couple things, right? Just a few. There's lots of proteins, there's lots of sugars, there's some bacteria, there's vitamins and minerals, there are white blood cells. And that's probably the most significant thing that we see when we look under the microscope at the breast milk versus formula. So you can see on the left, formula, there's nothing in it, right? Obviously there's things in it, but there's no cells. And breast milk has a ton more cells in it, somewhere between 1 and 5 million cells in a 1 ml aliquot, and that depends a little bit on when it's taken. Now, my husband wanted me to really talk about this because he's heard me tell this story. And some of my residents are here, and I've probably told you that before. So how are we supposed to make formula? Anybody know how to make formula? Yes. Butter and powder, right? So you have the pre-made formula, right, the ready-to-feed stuff, and you also have a powdered formula, which is what most people use because it's cheaper. the CDC and the World Health Organization's recommendation, as well as the AAP recommendation on how to make infant formula, is to boil the water and add that water. It has to be to a minimum of 158 degrees, and then you add that to the powder. Why? I see somebody back there. Bacteria, it's Chronobacter, right? So the powdered formula has been shown to be contaminated with Chronobacter. In the world, the United States has the greatest proportion of Chronobacter infections in babies because of the infant formula. That's over all of the third world countries as well. So the recommendation from the AAP, not the CDC, is to, for the first 3 months of the baby's life, to make that powder with the boiled formula. That no one's going to do that. When I talk to my moms about this, specifically I'll do it for my preterm babies or the babies who are failure to thrive, those babies that have underlying health issues. I'm telling them make a big batch of it at one time. Stick it in the refrigerator. They can then heat it up later so that we can get rid of that risk of the Chronobacter. Okay. The type of white blood cells that are there come from two places. One is from the breast, and one is from the blood. And they have different roles in the body, in the gut. We are still in the process of figuring out what those roles are. They are variable depending on the age of the baby as well as if there's any infection. Now, the milk changes. Anybody seen colostrum? Yeah. The colostrum is this sticky, thick yellow. Sometimes it's orangey in color. And the colostrum has some really important factors in it. It's really high in the immunoglobulin A. It's very high in some proteins. But it also is less of a source of nutrition and more of a factor of immunoprotection. It changes from this yellow, thick, slimy consistency to a creamier milk in the first 2 to 3 days. And mommies will tell you, oh my gosh, my milk has changed. And then it will continue over about 2 weeks into this mature milk. And the mature milk is where really a lot of the fat comes in, and you'll start to see more of a nutritional factor in comparison to the others. If mommies leave that milk bottle on the counter, some moms have called me and said, oh my gosh, my milk is bad because the fat layer has gone to the top, and what they see underneath is the foremilk. So the milk itself, once it's mature, starts to look a little different by itself. So the initial portion of the breast milk that comes out is almost like skim milk. It has this bluish hue to it. It's almost gray. And then after about 10 minutes, the hind milk starts to come in, and it looks much more like heavy cream. And mommies that are pumping will see that much better than if they are actually just nursing at the breast. But the breast milk can be other colors, too. It's important that mommies know that their milk is still okay. So what mommy's eating makes a difference in what the breast milk looks like. They've got pictures of beets there, but I've also seen it with lots of yellow vegetables. And you can also see a big change when mommy's had trauma to her nipples. And blood in the milk does not make the milk bad. So mommy's milk will be pink. Baby can still eat it. But what do you have to know about for the baby's stools? What is it going to look like? It's generally like a green, so that's like these little black or greenish flecks in there. As the milk starts to come in, the stools start to come to that yellow, seedy color, and it looks different than a formula-fed baby stool. But moms freak out when they see that dark coloring in there. All right, so variations in the breast milk. It changes from colostrum, looks very different from that transitional milk, which looks very different to that mature milk. It also changes based on gestational age. So the nutritional components, the vitamin components, as well as the immunoglobulin components are different. If the baby's born at 32 weeks versus the baby's born at 40 weeks versus this is a 2-month-old or a 6-month-old baby. And also with illnesses, and that's both with mom's illness and baby's illness. I'm going to go through that in a second. But it makes a big difference. This is a dynamic process. I tell moms that this is a symbiotic position. You need the baby needs you. You work together. Okay, breastfeeding helps gut health, and today we're going to talk about why. It's important that we go through a little bit of the innate immune system first. Is Laura here? Oh, good. I didn't want to talk about the immune system with our immunologist here. So, the innate immune system is what your body is born with. It's kind of this pre-programmed, not responsive to anything. It's just what you get. And the immune system in general for babies and mommies is suppressed during pregnancy, and that's to prevent an immune-mediated abortion. So rapidly, as soon as the baby comes out, we have to start revving that immune system up, and the breast milk does that. The innate immune system for the baby is the physical barriers. It's our skin. It's the intestinal wall. The chemical barriers, meaning the gut acid. It's the mucus that lines the intestinal wall. And also the local reaction of the white blood cells that are not specific to whatever they're approaching. And it takes almost a full year for that immune system to fully develop. Okay, I know this is busy, but I want you to see there are a ton of things that affect the gut flora, and this is just pure bacteria. So it starts with mom's gut, mom's health. If mommies are healthy, they give their babies better flora. One of the things that we used to think was that baby's gut was clean. It was sterile. It's not sterile. So baby's gut has, when they are born, specific things from the, they have a lot of Enterobacter, a lot of Lactobacillus, and a lot of Bifidobacterium that are coming from mom's gut, delivered prior to delivery itself. If mom has antibiotics, if the baby's born early, if they're born by C-section, that changes that gut flora right there. The breastfeeding actually supports those bacteria, and we'll talk a little bit about some of the ways that the bacteria can change in a second. But then you also have the post-feeding environment where our baby's getting antibiotics, or the environment that they live in will change a lot of the bacterial colonization. Okay, so we talked about mom's gut and being presented. So this happens both before, this portion here on the left happens before delivery, and then the rest of it happens consistently through breastfeeding. So the dendritic cells in mom's gut cross through the tight junction, grab a bacteria, usually it's a non-pathogenic because it's specific. Non-pathogenic bacteria comes back in and enters into mom's mesenteric lymphatic system. That gets then presented to the mammary gland. That dendritic cell pushes through the tight junctions, drops off that bacteria again, and it goes into the milk. That baby then will feed off of the breast, so you have mom's skin flora as well as the gut flora mixing with the baby's saliva, and that is how the baby's gut gets into it. We know that all of these factors don't happen immediately. I can't take a baby and just have them not have any of those other factors. But we know when we look down the line that babies that are breastfed have a different bacterial composition than babies who are formula fed. We know that they have less volume of bacteria. We know they have less diversity of bacteria. And the Lactobacillus and the Bifidobacter are the biggest predominance of the bacteria that's in there, versus the formula-fed babies have more of these two species, which is C. diff, staph, and strep air. Okay, I want to talk a little bit about those immunoglobulins that mommies are making. The secretory IgA is produced in pretty much any exocrine gland. It's in your saliva, right? It also is in anything that will kind of react. But specifically in the mammary glands, they have a upregulation of some of these processes and can make a difference differently than some of the other human functions. That didn't make any sense, so I'm going to move on. The IgA is the biggest proportion of the immunoglobulin that's in the milk. It's bigger than IgM and IgG, and that will change as the baby gets older, but IgA is still the highest. The other thing is that it's directly linked to mom's exposure. So I'm going to take a minute and talk to you about how the baby latches and what this shows. So So you can see how closely this baby is sitting at the breast. So I look at this and I don't see a perfect latch, and I'll tell you why. So this baby is tucked up into mommy's breast. He's got really good flanging of the upper and lower lips, which is great. This is the gum line, and you can see that baby's mouth is really wide, right? Versus at the bottom, the baby, it has a much more narrow portion of their mouth, and they tend to bite at the nipple itself. If they do that to mommy's nipple, it hurts like crazy. They don't like that. So that's why it's so important to get that baby's mouth so big and wide. It also will pull the nipple itself way back. It's almost to the back of the hard palate in the baby's mouth. And that makes it much more of a massage working from the tongue, the back of the tongue, not the front. And you can see how this baby's lips are really close, almost covering the whole areola. That varies a lot from mommy to mommy. But I don't like how this chin is not tucked up against that breast. The baby should be tucked in really close. Now what that does is they're very close in terms of their skin and their sharing of bodily fluids. Over here is the milk glands and the milk ducts, and finally the release. Now, this was in the lay press. With baby and mommy being so close, there's probably a little backwash in there. This was from Science News, and that actually has an important process. There's something called retrograde ductal flow. And what we think happens is baby is sick, mommy's not. Baby has the either the secretions from the nose or in the saliva with the antigen. It goes up through mom's ducts and into the mammary glands. Mom then creates the antibodies and increases the leukocytes in her milk and helps the baby fight that infection. That's cool, right? That's really cool. There is an article here that was showing kind of the white blood cell change, and the immunoglobulin is dynamic. It's always changing, but the leukocyte concentration is significantly more with infections. I didn't put this in here, but I found it so cool. Same thing with babies. Every baby spits up, right? So there is some correlation with baby spit up of breast milk having the IgA and the white blood cells going down into the lungs, and they think that may be partly protective for asthma because they're learning self at that point. I didn't have a whole lot of great ways to put that into here, but I thought that was really cool, versus that formula down in the lungs is purely an irritant. Now, mom's exposure in life comes across in what she presents to her baby. So we know that mommies that live in a underdeveloped or a lower socioeconomic bacteria colonization will be different than a mommy who lives in a first world country or in a higher socioeconomic group. So this study was done and specifically looked at, does it change? So there is a group of women. What they did in this study was they took mommies from Sri Lanka who were exposed in their day-to-day life to E. coli, and they measured what's the IgA levels of E. coli in mommy's milk. The top of that shows a lot. And you'll notice it's like 1 month of, there's 2 bars. 1 month is the black, and then at 6 months was the second time they measured it, is the striated line. And it's pretty high. There's a lot there. And then they took women who were from the general vicinity, not necessarily from Sri Lanka, but had moved, and they were now transplanted and living in London. So their exposure to E. coli was different. It's in the past. Their IgA to E. coli is still higher than the women who were from London and not exposed to E. coli as much. We think this relates to a couple things. The biggest one is that mommy's immune system remembers that exposure and presents it to her baby through her breast milk. Okay, I'm going to move on to the next one. So we've talked about the bacteria. We've talked a little bit about the immunoglobulin, and now we're going to talk about lactoferrin. Anybody heard about lactoferrin? We order lactoferrins all the time, right? This is why you don't order a lactoferrin on a baby who's breastfeeding, okay? Lactoferrin is produced in the breast milk and produced in pretty high quantities, and it has some amazing properties. A lot of the data that we have on what lactoferrin does comes from the dairy industry because they are using it, and my dear friend who was a dairy farmer, I don't know if you ever used this on the farm. Yeah. So lactoferrin is something that they're looking at adding to our cow's milk. They're looking, I've actually seen it in GNC. It has some pretty good properties, nonetheless. In the breast milk, it's produced in the mammary glands and excreted into the milk. It is responsive to illnesses. So we know if baby is sick, mommy is sick, mommy's lactoferrin levels climb. And we think that has a direct suppression of the inflammatory process in the gut, which is pretty interesting. You've got an infection, but you're calming down some of the processes in there. They are selective. So we think of lactoferrin as a binder to the gut, to iron itself, and it does this exclusively as a way to make the iron that's in the gut more bioavailable to the baby. So if you measure iron, there's more iron in formula than there is in breast milk. However, the iron in the formula is not as bioavailable, so that's why they need so much more. And it's an additive. It's almost 100% bioavailable from the breast milk because of lactoferrin. But its other purpose in the gut is to bind the iron so that the other bacteria don't have access to it. So they almost starve the bacteria, the pathogenic bacteria, because they don't have that substrate. Lactoferrin itself, without iron bound, can actually break bacterial cells. So it has, in and of itself, a bacterial vital property. Now, we talked a little bit about the immune suppression. It does both. It will increase the cytokines and decrease the cytokines. I did not give you all of the numbers and letters, which is why I was glad Laura wasn't. Because I don't think most of us understand and can put that into any semblance of memory to be able to say that the 6 versus the 5 versus the 12. But regardless, there's pro-inflammatory cytokine and anti-inflammatory cytokine production. It changes the cells itself, so it can make the phagocytes more mobile. It increases the natural killer cells, and it can change the lymphocyte maturity. It also can bind directly to the epithelial wall and make it more difficult for the bacteria to get into the cell wall. Anybody here heard of human milk oligosaccharides? This is an advertisement. So HMOs are now being added to the formulas. So that should tell you there's a lot of benefit somewhere, right? They have identified this, and it really has a great activity in the gut. So they serve as prebiotics. They're the food for the good bacteria. And it's specific to the bifidobacteria and the lactobacillus. It can change the gut pH right from the get-go, and it's dynamic. And there's been some studies that have looked at individual proteins that are formed to bind E. coli and salmonella, viruses and fungi, all part of the human milk oligosaccharide. So you can see it is a dynamic process. It fits a bunch of different places, works at the good bacteria, binds and prevents the pathogenic bacteria. It actually can help with, it looks like the viruses is based on competition, not necessarily that the binding is the predominant factor, although it does both. It can actually help with the epithelial wall proliferation, so those actual cells are making regeneration, and it can change the mucosal layer as well. So this one's my favorite. Not from human milk. Again, another advertisement. And you'll see this on some of the cans. Okay, so the different components of the breast milk that have that immunologic benefit. So that we talked about the immunoglobulins, we talked about the bacteria, we talked about the lactoferrin, we talked about human milk oligosaccharides. These are pure enzymes that are actually in both the saliva and in the gut, as well as in the breast milk itself, and its only job is to lyse cells. Again, not in formula. And adding all of these processes together, you will see the differences or the continuum of protection from mom to the gut itself. Now, all of this plays an individual role for the baby in the gut. Now we're going to look a little broader and talk a little bit about how this changes disease and disease processes and the big picture. So epigenetics literally means on top of genes. So we know that the expression of genes is influenced by other factors. And the other factors is the nutrition and the microbiome in this process. And if we look at a couple things, we'll see these are the ones that are probably the most well established and developed. So there were a couple of us that went to the Chicago meeting of the AAP, and Dr. Robert Lawrence did a wonderful presentation at the plenary session that talked a little bit about birth weight. So pure and simple, mommies who breastfeed, their grandchildren have a higher birth weight, not accounting for any other factor. Pure and simple. Correlation, and we think that's related to the epigenetics. We know that women who have a BRCA1 gene express differently, and their rates of breastfeeding, their rates of breast cancer are significantly different than someone who did not breastfeed. And there's a correlation with cholesterol, too. That one's still being worked out. Okay, so I just wanted to show you some of the things that are hypothesized or being evaluated. The different factors in the breast milk, the lactoferrin. We talked a little bit about the oligosaccharides. As an aside, the human milk oligosaccharide is undigestible. It's why the stools are so soft, right? It's just this fibrous content. And it has a direct effect for certain illnesses as well as what it's doing on the gene expression. And it's both hypothesized in humans based on some in vitro or animal studies. Again, a lot in rats, a lot in the dairy industry. The neck, we think that's related to the lactoferrin, not related to the bacteria itself, and just the immune moderators that go associated with that. And it's the reason why the recommendation is that babies that are, especially the premature babies or the low birth weight babies, are started with their feedings on mommy's milk. So the NICU does an amazing job here of encouraging mom to collect and store her milk and then use that as the first feeding. The recommendation is once those feedings are done, if mommy can't sustain that milk, you go to donor milk. Donor milk is not nearly as beneficial, does not have a lot of the dynamic and alive processes in it, but it still has less of the inflammatory things that the formula does, and then eventually weaning off of that. Okay, this is what it looks like on the big picture. So, exclusive breastfeeding. The definition of exclusive breastfeeding is never had an alternative source. For the AAP, the CDC use 6 months is their kind of guideline, but exclusive breastfeeding protection decreases hospitalizations by 50%. That's pretty impressive, and it's specifically related to lower respiratory infections. So it's RSV. I'd be curious to know, of all the babies that have been in the hospital with RSV, how many of them were breastfed? Not very many, right? The neck rate is down by 58%. SIDS is decreased by 73%. ALL doesn't correlate with any of the other malignancies, but ALL is down by 52%. And it has long-term reaching effects, so obesity and type 1 diabetes is significantly less. The Lancet article, I would encourage anybody, if they're interested, to go and look at this one. This was a symposium that was done in Lancet. It was 2 different articles that they put out, and the it was a meta-analysis of all of the research from all of the countries around the world and tried to correlate and pick out and tease out the beneficial things that were there and looking at and correcting for the different dynamics of how the studies were done. It was a pretty good read and actually had some pretty good information that is usable. For the babies, we know that breastfed babies have less ear infections. We know that they have less respiratory infections. We know that babies have less deformities of their mouth. You have a flat nipple that goes into the mouth and stays right in the center. The binky mouth, that's that channel on the roof of their mouth, that is associated with sinus infections, it's associated with ear infections, it's associated with malocclusion and difficulties with dentistry, right? The breast goes in deeper, it's wider, the baby's mouth is different, and one of the reasons why we think the babies have less ear infections is because of pure structure, the way that they're pulling, they're actually changing the eustachian tube. It's being massaged in a different way to decrease the amount of fluid that stays there. When we look at the data long term and try and correlate what really is real, because people have made claims or hypothesized that breastfeeding is the cure-all for everything. And I'm sure it helps a lot of things, but there has not been significant correlation between certain long-term effects. Now, asthma, celiac, multiple sclerosis, type 1 diabetes, very strong data that breastfeeding is protective. As we get further along this slide, you'll see there's less and less of that data to correlate. Lupus is one of those things that is in the literature a lot about should mommies or should mommies not breastfeed if they have lupus. And this is an interesting correlation. Prolactin is one of, obviously, the milk-producing hormones. And the prolactin levels are really high, and it's been shown to set mommies off with their lupus flares. So depending on who you talk to and how well mommy is controlled, you'll hear different suggestions on whether mommy should be allowed to breastfeed or not. We know that moms have benefits too. Absolutely a change in the way that her breast cancer risk, her ovarian cancer risk, diabetes, and depression. And it's been quantified. So this came out of the Surgeon General's call to action. So mommy's risk of type 2 diabetes is 8% higher if she never breastfed. Ovarian cancer, 27% higher. This breast cancer, this is confusing, and I had to read it several times. So if mommy never breastfed versus if she ever breastfed, and it didn't have to be exclusive, and per year of breastfeeding, so I breastfed my babies about 5 years, my risk of breast cancer is going to be significantly less, by about 20%. It happens for all socioeconomic groups, but we know, going back to the environment that they're living in, women who are in lower socioeconomic groups, their benefit and for their babies is greater than in a higher socioeconomic group. I would be remiss if I didn't go through the contraindications to breastfeeding. Not everybody can breastfeed. Pardon me. Everybody has the potential. And definitely, there are some women who cannot, and these are the things that we would medically say, this is off the table, it's not available. So HIV infection, but only in the U.S. So every other place in the world, the recommendation is to breastfeed your baby because the sanitation is not there. They're at greater risk of dying from the poor water quality than they are from the HIV that they may get crossed. Human teeth, lymphotropic virus, substance abuse or alcohol abuse that is untreated. If it's not well controlled, mommy shouldn't be breastfeeding. Active or untreated TB, certain medications that are obviously pretty dangerous to a baby, but almost every other class of medicine, there's an alternative somewhere in that class that is safe for mommies to take for almost every reason. Mommy's undergoing radiation therapy, if she has untreated varicella, or if she has active herpes lesions on the breast. If they're not on the breast, you can cover that and still feed. She doesn't like that answer. Okay, so from that Lancet article, human breast milk is therefore not only a perfectly adapted nutritional supply for the infant, but probably the most specific personalized medicine that he or she is likely to receive, given at a time when gene expression is being fine-tuned for life. This is an opportunity for health imprinting that should not be missed. Now, I'm going to talk a little bit about kind of global perspectives and the guidelines and the recommendations. You've probably heard most of them, so I'm not going to spend a ton of time on it. The World Health Organization says infants should be exclusively breastfed for up to 6 months of age and continue with a partial pattern until the infant is at least 2 years of age. I chose this slide for a couple reasons. The first one being, it points out the United States is the only, well, there's 5 countries, I'll be clear. But we're the only industrialized country in the world that doesn't have a paid maternity leave. Look at Africa. Look at South America. We're the only one. And my Canadian friend. Okay. The American policy on breastfeeding. American Academy of Pediatrics recommends exclusive breastfeeding for about 6 months, followed by continued breastfeeding as complementary foods are introduced, with continuation of breastfeeding for 1 year or longer as mutually desired by the mother and infant. In 2011, the Surgeon General was Dr. Regina Benjamin, and she put out a call to action. The call to actions are kind of there's multiple of them. They are kind of a state of the union, so to speak, and their idea is to identify problems and work towards solutions. And in Dr. Benjamin's her call to action, she looked at a couple things and created a roadmap of how we, as a community, as parents, as the medical community, as employers, researchers, and on the global perspective, make a difference in mommy's lives. So it went from very small, how can we approach and make it easier for mommies to breastfeed successfully, to the big, broader picture of society. UNICEF, their entire goal is to support children, keep them healthy. So nutrition and safety are important in their entire goal for the world. And they created this baby-friendly initiative. Now, Alex told me this was going to be a little bit controversial. So I'm going to take you through a basic steps. Now, I don't think breastfeeding is controversial. I am sitting on the pulpit, though. And the implementation, I think, is the controversial part. How do we change our system that we can support mommies in a way that's not contraindicated? So this you've probably seen on the mother-baby flora. It's there. I'm assuming it's on the labor and delivery because it takes a lot of, is it there on labor and delivery? No? Should be. And it is pretty much a basic thing for the hospital system. That's all this is. And it goes through a couple things. So we need a policy. We need to train people on the policy, and we need to assist mommies, right? So helping mommies initiate breastfeeding with 1 hour of birth, holy cow, was that a hard one to make happen because of all the details that went into that. But there's a reason behind that. So mommy's greatest level of prolactin in the first hour after delivery. So if you can get that baby to the breast to stimulate that prolactin level, her levels will fall slower and you have a greater milk production. That's clear. If you wait and it's 2 hours, 3 hours, 4 hours later, mommy's potential for breast milk production is less. Healthy People 2020 is a initiative by the CDC, and it looks, again, very similar to the call to action. It looks at the big perspective. It's the social environment, it's individual behaviors, it's the where people are living, and it's also nutrition going into it. Healthy People 2020's goal for breastfeeding is pretty lofty. So this is where we're at currently. We're actually a little bit higher than this because this is 2016, but the numbers are not that much different. So 76% of women in the United States have ever breastfed. At 6 months, 49% are breastfeeding a little, but not exclusive, because 16% are breastfeeding exclusively at six months of age. But we'd like to see these numbers shift and climb. And the initiatives that we have talked about are all aiming toward these changes. We know that a lot of mommies start breastfeeding. They want to breastfeed. They've heard the message. They know that this is the best for their baby. And somewhere in this process, we lose their will or their ability, and there's a couple of reasons for that. So we know that mommies who are pregnant make a decision about how they're going to feed their baby generally before the first trimester is over. So our role is to be in there and talking to them about what that means and the benefits of it. And every visit you have with them, talking about the benefits to them and to the baby, it's not equal to a formula bottle. So somewhere between 80% starting at birth and 50%, that's a pretty big jump. And only 22% are exclusively breastfeeding at 6 months of age. Now, this is from 2012. I picked this one because it was pretty, and the 2016 data was not that significantly different. So the Agency for Healthcare Research and Quality, the director for primary care, said, the evidence suggests that the debate over the relative value of breastfeeding compared with artificial means of feeding is over, as the data are unequivocal in favor of breastfeeding. The challenge must now be to establish appropriate systems and resources to support women and families who are interested in breastfeeding. So now's the big hard work, right? And it comes in a couple different ways. It is helping mommies through the entire process. It's not just in the first hour after delivery. Things change. It's dynamic, and they need that assistance. How many people, maybe I don't want to do this, how many people have ever had anybody ask them a question about breast milk or breastfeeding? Almost the whole room. Who feels comfortable answering those questions? All right. That's fantastic, because it makes a big difference. They feel like they're in left field when they don't have the ability to ask questions and get answers, right? It's imperative. And I can't tell you how many people have said to me, I wish I had known, or I wish I had had help, or I wish I'd had better help, or I wish I had. There's a lot of regret associated with not being able to breastfeed. It's the only thing I'm going to say on this, because I could go into another 3 hours on how to breastfeed. Demand equals supply. If you don't get the milk out, there is no supply being made. The pump is not effective. I'm going to say it again, because when I walk into the newborn nursery and I see mom with a pump next to her or on her and the baby's in the crib, it drives me crazy. The baby is going to get out that milk a whole lot better than the pump is. The baby is going to have a positive and a negative pressure on those milk glands. The pump is just negative pressure. There's not any correlation there. It has to be the baby. And it has to be a good latch, or it's painful and you give up and you have to, and I've absolutely been in that situation. You call your friend crying, how do I do this, right? So it has to come out. There are a ton of resources out there, because we as physicians and providers can't do it by ourselves. We can't be there all the way around. And parents are searching this information out without you. So you need to at least give them good places to go. In our area, our lactation consultants, both in the hospital and outside of the hospital, are fantastic. They do a really good job, and they are doing a good job of kind of communicating back and forth. There are a ton of support groups. The Lactate League in this area is not very big, but there is a group in town called the breastroanoke.org. I do not tell people to go there. I wanted you to see that, because if you see the website, if you go searching. I don't have any, I haven't had any positive or negative responses to this website, but I don't have any confidence in their facilities just based on what I've seen. And so it's a lot of, the website looks great, but I haven't heard anything in the community, and that's where you're going to get that hands-on assistance. Lots of moms go to Kelly Mom. Kelly Mom has a ton of information. They had on there a couple expert discussions where they have brought in people from all over the country, and they're talking about the science behind it, as well as there are videos on there on how to help mommies do this. There are videos on Google, and mommies use them. So if you're not giving them that advice, they're going to go searching for it. 2 places I'm going to point some of the residents and medical students to. The HRIA Institute is out of Boston, and the wellstart.org, both of which have some pretty good tutorials. The CME tutorial you can actually get from the HRI. WellStart is, was actually designed to be a resident training program. Almost every week, Daphne and I get a telephone call, is this medicine safe? And I get that question for lots of reasons. Mom is going to take a medicine. Mom is sick, wants to take a medicine. Mom is having surgery. Is it okay? Will you talk to the anesthesiologist and tell him I can't have such and such and such and such? And the whole idea behind this is you need resources on how to do this. 2 resources that are great. My favorite is Dr. Hale's book. This is his newest edition in 2019. Dr. Robert Hale is a pharmacist, actually, and he's a professor of pediatrics at Texas Tech, and he's done most of the clinical research on safety of medications in breast milk. He's currently doing a study on marijuana and safety and metabolic changes in breast milk and how much is too much and so on and so forth. Anyway, the other one is LactMed. This one's free, goes on your phone. At one point, those 2 resources didn't match very well. There wasn't as great information, but LactMed has really kind of picked up a lot, and there's a whole lot more opportunity on there. And it almost matches Dr. Hale's stuff, at least from the previous edition. We need some support for mommies, both in the hospital immediately and afterwards. There are entire cultures, societies, where they support mommies by they go home and then they have a nurse go to them to help them with nursing. That's their only job, is to assess that baby and assess nursing. We don't have that in our community. It would be invaluable. Day 1 of nursing and day 4 of nursing look very different because mommy's supply is in. And sometimes it's easier and sometimes it's not. We also need support in our acute care scenarios. So mommy's being hospitalized. Mommy is having surgery. Baby is having surgery. Baby is hospitalized for whatever reason. We can support mom through nursing in all of those scenarios. One of the women in this community, she's a PICU attending and a lactation consultant. And she loves to go to the PICU, and all the nurses, this is actually at the University of Maryland, and the nurses love when she's on call because she helps the mommies nurse their babies. And she was giving the story of a child who had finally been extubated following their cardiac open heart surgery. And she created a scenario and put the baby to the breast. His heart rate calmed and his oxygen levels climbed. And that's what we see. It's a comfort for them. And if you can maintain that supply, that baby can go back. You don't pull that, you don't have that demand, the supply drops. There are a couple resources that I want you guys to have access to and know that they exist. The CDC, the World Health Organization, 1,000 Days, all kind of give some basic information. The AAP section on breastfeeding, fantastic. The Academy of Breastfeeding Medicine has built a ton of protocols. So how do I treat and care for the baby whose mommy has mastitis? Do you stop that baby from nursing? No, that baby needs to nurse through that, right? They need to nurse. Abscesses, not so much. My sister, the one that I showed you in the beginning, lives in Germany. Baby was about 7 months old. she developed a mastitis. In Germany, she got admitted for 5 days with antibiotics. First day she walked in, they said, "You must stop breastfeeding," in their broken German. "You must stop breastfeeding." And she said, "I have nursed 2 babies. My pediatrician sister says, no way, you're not stopping." And I pulled all the data. What do I need to do? What do I need to do? And they kept giving her these medicines to stop. She said, "Thank you very much." And she would take the medicine and throw it away. And her husband would sneak the baby in so that she could nurse. And she'd breastfeed the baby, but there's so many good factors to that. You actually decrease the amount of the swelling that's there. The baby gets all of the immunoglobulin and all of the white blood cells that are in that too. Abscesses, the recommendation is to not nurse on the abscess side, but you continue to nurse. I see people nodding their heads. I'm so excited about that. You nurse on the opposite side, and mommies can have a full supply on one side. There's protocols on how to take care of the baby who gets admitted for hyperbilirubinemia, for the baby who has failure to thrive, to sustain that nursing. We know that the formula is inflammatory. All right, so we talked about a bunch of things. We talked about the gut flora and the regulation of the immune response. We talked about supporting mommies, and we talked about the long-term health outcomes. Breastfeeding rocks. I have a couple of questions that I need to go through. So, number 1, what immune compound secreted in breast milk acts as a barrier to invasive pathogens and serves as iron transport in the infant's gut? A is IgA, B is lactoferrin, C is human milk oligosaccharides, and D is the fat globules. What is it? B, it's the lactoferrin. Question number 2. Exclusive breastfeeding has been associated with a reduction in all of the following diseases in children except A, obesity, B, lower respiratory infections, C, malocclusion, D, arthritis, and E, otitis media. D, arthritis. Although it is in question, they are still researching it. And last one, what pediatric health initiative encourages exclusive breastfeeding for babies the first 6 months of life? A, the AAP, B, the World Health Organization, C, the CDC, D, UNICEF, and E, all of the above. All of the above. That's right. So I'm happy to help. If anybody has questions or concerns either today or in the future, I am happy to help guide and either give you resources or walk you through. This is a in evolution process. Most of the resources that I talked about have like a listserv, and we all talk about, this is my problem, this is how I handle, and sometimes they're weird, but you'll be surprised at the resources you find. And a quick one that's kind of fun. Women in the military. They have to be out there on the range. They're exposed to all kinds of metals and gun exposure, and there's an entire website called Breastfeeding in Combat Boots. It's a great one, and it's supposed to support women through their active military duty, and it takes them through all of the guidelines, all of the recommendations, and the changes that the military will make to be able to keep the mommies nursing. I had a mommy who was I think she was a major in the National Guard, and she had to go and spend 3 days at the shooting range, and it was indoors. And her commanding officer came to her and said, "You're not doing this until I know for sure that you and your baby are safe." And he did this entire study on the safety of the air quality and lead exposure for the entire unit just so that he could make sure she was safe. That support is out there. You just have to know how to get it. Questions?
Any questions in the room? Question? All right. You're all the way in the back. I don't know.
So with the prolactin level being so high first hour after, I know that you don't like breast pumps, but some babies,
Absolutely.
my babies can't.
Absolutely. But that's a newborn nursery. It's few and far between that mommy can't put the baby to the breast in the nursery.
But for our babies, would it be beneficial for them when we usually put the baby on their chest if we just put a breast pump on mom in that first hour?
No. So the recommendation is put the baby to the breast first.
But if they can't, they're a 28-weeker.
So you're not putting the baby to the breast. Is that what you're saying?
Right. We can't.
So That's not the recommendation. So the recommendation is to let mommy bond if they can, put the baby to the breast if they can, and if they can't, then you get that mommy pumping with hand expression. And there's some really good data out of the NICUs that mommy's pumping with hand expression dramatically increases their milk production by 40% with hand expression versus pumping alone. Oh, you guys look at your nurses aren't doing. You're not teaching them hand expression.
Well, we're not seeing the moms in the first hour of life. In general, our nurses don't. It's the L&D people who are seeing them.
But I'm sorry.
Okay,
Yeah.
But I've often just told them to start pumping as soon as they can. And
if mommy's not safe, mommy's not in a medically stable position, you can't, right?
But if mommy's okay, because she just delivered a 28-weeker vaginally, she's okay. It's the baby who's upstairs.
Yep.
So is the first hour with whatever she does, is that important if the baby's not there?
Yes. So if the baby cannot be there, then pumping with hand expression is your second best. And hand expression is actually better than the pump alone. So if you have to pick one or the other, hand expression, and there's a ton of videos out there, your lactation consultants know how to do this. There's a way to be able to help those mommies do it. It's pretty impressive.
With SLE, is it more controversial because of the maternal disease process and potential inflammatory? Is there a controversy if mom can do it? Is there any downside to the baby?
No.
Okay, so it's maternal process.
It is if we're going to flare mommy's lupus.
The 76% for U.S. breastfeeding rate seems high for the population that I see. Is there a strong ethnic variation in breastfeeding rates?
Yes. Oh, that's a really good. Oh, and that's a whole lecture all to itself. So there's a very disparate amount of mommies who are nursing. We know used to be that it was only the poor people who would breastfeed their babies because they didn't have the alternatives. I have a great story of my great-grandmother who was a wet nurse scaring the heck out of me when I was a prepubescent girl. But now it's the higher socioeconomic groups that are, and the more educated mommies who are nursing. Interestingly, though, mommies who have a lower socioeconomic group have better outcomes than those from higher socioeconomic groups if they breastfeed. And there's this whole grassroots initiative to be able to support mommies in different ethnic groups and lower socioeconomic groups to be able to encourage them to nurse. There's one of my former partners is actually in D.C. now, and she is going to go and give a presentation to essentially WIC up there to try and get mommies to try and breastfeed. She made a big point on African Americans. She wanted them to know that I can be a role model for these mommies, that yes, you can breastfeed, but absolutely, huge difference. But that 80% is across the board. We know even the lower socioeconomic mommies will start. They don't continue. They fall off faster. You know what the fastest rate of drop is? The fastest group, let me put it that way. The group that drops breastfeeding the fastest, women physicians. And that's all support.
I think we are right at 8:30. So thank you very much.
Thank you.